Thanks a lot, Jeff. A great talk on the replacement technologies that are kind of perpetually in the offing with clinical trial development. And we're very fortunate at UPMC to have access to a number of these different clinical trials. But an important patient population, or when we're grooming these patients to be in these clinical trials, we have to think about their heart failure management. Not only is it a requirement to entry into these clinical trials, but it's just appropriate management in general. So to discuss that a little bit more is Jennifer Kliner with regards to, does heart failure management and heart valve disease work?
Thank you, and thank you for having me here today. So heart failure management and valvular heart disease. We'll start with the definition. Heart failure is structural heart disease and evidence of elevated filling pressures. Historically, we had two categories of these patients. Heart failure with reduced ejection fraction, or HFrEF, and those are patients with an LVEF less than 40%, and the patients with heart failure preserved ejection fraction with an LVEF greater than 50%. Last year, in April 2022, our new guidelines came out and they added a heart failure mid-range ejection fraction category. And that's important for those patients that fall in between the HFrEF and HFpEF. These are patients with a left ventricular ejection fraction of 41 to 49%. For this talk, I'm going to focus solely on the HFrEF patient population. So why is it important to talk about heart failure management at a valvular symposium? It's because these patients are going to come to you through your valve clinics. They're going to be referred for mitral valve intervention and surgery, and if they have reduced ejection fraction, we really need to be managing them per the guidelines. And you can see at the bottom of the algorithm are all of the interventions, right? This is what we've been talking about all day. But if you feed the algorithm back up to the beginning, it starts with guideline-directed medical therapy managed by a heart failure specialist. So this is an important step that often may not be done when these patients get referred to you. So what does GDMT, or guideline-directed medical therapy, look like in functional MR with LV dysfunction? It's the same as with isolated LV dysfunction. Quadruple therapy is the standard of care. These include our beta blockers, our ACE, ARBs, and ARNIs, MRAs, and SGLT2s, which are our newest category that made it into the guidelines. The estimated cumulative effect of these four medications is a 73% relative risk reduction in mortality over 2 years. So it's not trivial. And most importantly, the goal of GDMT is to get patients on the clinical trial defined target doses. That's very important that we strive to not only get therapy on, but to up-titrate it where we know patients will get their best benefit. These are the target doses that we strive to get to. I won't spend any time on ACE or ARBs because I think, as we all know, they've fallen out of favor. To ARNIs, I'll just focus your attention on the Entresto dosing. So sacubitril valsartan, max dose that we should be striving for is 97/103 twice a day. Beta blockers, metoprolol succinate, 200 once a day, and carvedilol based on weight, 25 or 50 twice a day. MRAs and SGLT2s a little bit easier, not much dose titration for the MRAs, and SGLT2s is one dose. So empagliflozin and dapagliflozin, they don't need any work once they're added on. So how are we doing with guideline-directed medical therapy? Well, according to the CHAMP Heart Failure Registry, which looked at over 3,500 outpatient management of heart failure, patients on targeted doses of each therapy was less than 20%. And 1% of eligible patients were prescribed triple therapy. Now, this is before SGLT2s were in the guidelines. Now that it's quadruple therapy, we can assume that we're pretty close to the 1%, if not still even a little bit less. So why is that? We know these medicines work. We know what they are. Why is it so hard to get patients on therapy? It's because it's very labor and resource intensive, right? These patients don't want to come to the office once a week for dose titrations. There isn't any physician in this room that has the availability to see their patients once a week for dose titrations. Inconsistent follow-up. We see a patient in clinic, we start them on low-dose beta blocker, and we say, call in a week with your blood pressures and we'll adjust your medicine. And they never call, they show up 3 months later for their follow-up echo, and they're on essentially no GDMT, and we've lost a lot of important time. Delay with communication and frequent dose changes. This is difficult for patients, right? They need a lot, 4 new medications, 2 of which have significant dose adjustments, so it's a lot for them to handle. The other piece that's very difficult for patients to navigate is the cost and coverage. Some of these medications require prior authorizations and are costly, and it's difficult as a patient, even as a provider, to navigate some of those cost constraints. This data was just released about 2 days ago, looking at guideline-directed medical therapy and co-op. So we were looking at the reasons and the rates of intolerability of GDMT. So for the patients who had, in the co-op trial, who had an LVEF of less than 40%, it was 464 patients. You can see that by figure A, 38.8% of those patients were on triple therapy. Again, before SGLT2 was in the guidelines. The most tolerable category of medication was beta blockers, followed by ACE, ARB, and ARNI, and then the MRAs. The most frequent cited reason for drug intolerability was hypotension, followed by renal dysfunction. And only 2.2% of patients were at gold doses of all 3 guideline-directed medical therapy. So what do we do about that? How do we fix that? Well, at our institution, we've created a medication optimization clinic. We refer to it as the MOC, and it's a 12-week advanced practice provider, so nurse practitioners and physician's assistant-led clinic for patients with HFrEF, and we use structured algorithms for rapid initiation and up titration of medications. These patients have appointments once a week for the full 12 weeks, in which we call them and review labs, vital signs, symptoms, and medication side effect. Medications are adjusted weekly as tolerated. We assist with all the copay, prior authorization, insurance, peer-to-peer reviews, everything that we need to get to assure that patients can have access to therapy. And again, captive audience, so we provide heart failure education. The goal is to get 4 drugs on by 4 weeks and then use the following weeks for subsequent up titrations. When we first looked at our data at our single center 18 months, we had 206 patients that came through our medication optimization clinic. Comparing that to a 2-to-1 propensity matching control group of 412, we saw that we were successful in decreasing both heart failure and cardiovascular hospitalizations at the 3 and 6 month mark. We also were able to increase the number of patients on quadruple therapy from 6% to 49%. So this was really exciting for us to see that this actually works, but the question we got over and over was, is this scalable? Yes, it's often easy to do these things at a large academic medical center where you have more resources, but is this reasonable to think that we could scale this across the system? So we did just that. We expanded to 7 sites across the health system for a total of 10 advanced practice providers, and they were across the entire state, so different demographic areas. And we're fully integrated into our valve center. So if a patient is referred for mitral valve evaluation and they have a low EF, it's an automatic referral to the medication optimization clinic. So we re-looked at our data at a little over the 2.5-year mark. And I know this is a busy slide, so I will slim it down to the important things. Looking at our N, which is now 772 patients who came through the medication clinic, compared again to a 2-to-1 matching of a little over 1,500 patients. Not only were we successful in getting folks on therapy and getting to that 50 to 100% target dose, we were consistent in that increase in quadruple therapy. So we were able to increase the number of patients on quadruple therapy from 9.7% to 50.1%. So again, a significant improvement in therapy. Most importantly, what does this look like for hospitalizations? So if we are looking at heart failure hospitalizations at 3, 6, and 12 months, as well as cardiovascular hospitalizations at 3, 6, and 12 months, we were able to impact all of that. Heart failure hospitalizations at 12 months were decreased from 23.8% to 8.42%. So a significant decrease. Mortality at 3, 6, and 9 months, also significant decrease. If we're looking at the 1-year mortality data, that was able to be decreased from 10.9% to 1.68%. I wanted to show this Kaplan-Meier's curve for the mortality at 12 months, only to point out one point. You can see the separation begins early. So these patients are getting effect almost immediately by being put on guideline-directed medical therapy. And that's important because we have to stress that we can't wait to refer these patients. When they're identified as having low EF, we need to get them on therapy quickly. And also, this is the reason that we're not quick to scale back on therapy. If a patient isn't doing well, we want to try looking at all other avenues before we scale back because we know it's beneficial. So in summary, dedicated medication optimization clinics are effective for rapid initiation and up-titration of guideline-directed medical therapy. We should all strive to achieve the target doses of therapy. And to treat the valve, we must treat the ventricle. Medication optimization clinics are scalable, and patients managed through medication optimization clinics have a 3- to 4-fold reduction in hospitalizations and mortality. So it may be labor intensive, it may require resources, but it's the right thing to do, and doing the right thing is never the wrong thing. Thank you.